Can you hear me okay? Thank you so much for coming today. I know that this is a stressful day, and yet you show up. So that's great. So we have a guest speaker today, Ms. Susan Morabit. She is, like you've met her before, she's TAing with this course, and she is an expert because she is an infectious disease nurse with the Georgia EIP program out of CDC, and she'll talk to you more about it. So feel free to ask her questions. A little housekeeping detail. So this afternoon, our test, again, is from 4 to 5, and there will be 2 different rooms. PO1, I don't really like that room, but that is the option that we have, and then 108. Do you have any questions about the section? Yeah. I post it on announcement. So it goes by last name, and the 2 sections will be mixed. So, you know, you'll see that section 1 goes from A to something, something, and then so on and so forth. So that if that's your last name, then you do that, okay? Everybody have done Exemplify before, right? On Monday? Any glitch that day? Okay, very good. And then we're trying to schedule the exam review next Wednesday in between your classes. So next Wednesday, I will let Dr. Edwards handle all the details in terms of room, but I believe that it's going to be between 12:30 and 1:30. So you guys don't have a whole lot of time, you know, like class, review, and class. So you'll be exhausted. But that's the only time that we could do exam review. So she'll make more announcements. So just a reminder that I'm heading out of town this Friday, and she won't be back until the 17th, so there'll be 2 days where we won't be around. But you can shoot us some emails, and you know, if we happen to have Wi-Fi, then we'll try to answer your question. Okay? Any other questions or concern? All right. Have a good lecture today.
Okay, so again, my name is Susan Morabit, and as Dr. Fan said, can everybody hear me okay? Is that better? Is it better? Okay. And I work for the Georgia Emerging Infections Program, which is a program out of the Centers for Disease Control. And the first day, I think I told you all a little bit about my background, and did you have a question? Oh, okay. Okay. Is that better? Okay, great. I have a master's in community and public health, and I also am certified public health clinical nurse specialist. So I am presenting on epidemiology and infectious disease for you all today. I do have this slide up. This is actually your first question, so you guys kind of get a head start because I couldn't figure out how to make it just give you the information. But if you want to go ahead and log into Poll Everywhere, you can either do it on the computer, which is the first, the pollev.com, and then my particular screen, or you can text Susan Morabit 477 to that number, and that will allow you to respond either on the computer or on your cell phone. And hopefully that'll all go. Don't respond now. This question will come later. But I just wanted you all to have that information to get logged in or text in before we get to the questions. Has anyone in here used Poll Everywhere in another class or no? Okay, so this is an experiment for both of us. Great. Perfect. All right, did everybody get the information to get logged in or text? Yeah, we're all good? Okay. All right. So this first section, we're going to be talking about epidemiology. The objectives are listed out here, and they're actually kind of color-coded, so as the objective color matches the section that we'll be speaking about, so you can see the direct correlation between what the objectives are and the information that's going to be covered in the presentation. Just show of hands or yays, nays. Anybody have any experience with epidemiology or epi-statistics or a little bit? Okay. Okay, great. So some of this might be a review for you all. And also remember that a lot of this information, it sounds like a lot. It's something you can always go back to your book and reference. It's not something that you will be tested on for NCLEX. This is information for you. Once you are a nurse, we can use this information when you're looking at research studies or doing your own research to help you in those areas. It helps if I put it in full screen mode, doesn't it? Well, there we go. That makes it a little easier to see, huh? Okay. So this is John Snow. He's considered one of the first epidemiologists. I like to think alongside with Florence Nightingale because they were both doing similar type things epidemiologically at the same time frame. So this is his map that he drew of the cholera deaths in London in it was about 1854. I think you can see it on there. There was a certain well that the majority of people who were getting cholera seemed to be using, and he used this map to figure out, well, where are all these people who are ill? Where are they getting their water source from? So during this outbreak of cholera, he was able to identify by looking at each case of cholera, each person who had contracted cholera, and showed a close association between those people who were getting ill and a specific water pump. When they removed the handle of that water pump, so it was taken out of use, the cholera outbreak, and put an end to the epidemic because it was that particular well that was contaminated. So this was kind of the first use of looking at cause and relation between illness and where people are and where the point of infection was coming from. So, this was just natural experiment. Well, where are these people getting sick? Why are they getting sick? And what do they all have in common? And for John Snow, it was the water pump. So, two refinements in research methods during the 18th and 19th centuries. These were critical for the formation of the epidemiologic methods, the use of comparison groups. Who's getting sick, who's not getting sick? What do they have in common? What do they not have in common? The development of quantitative techniques using numeric measurements to say, this group of people, there's 30 people over here using this pump getting sick. There's 30 people over here using a different pump not getting sick. So it was kind of simple, but it was the beginning of our basis for epidemiology today. So it's a Greek word, study of what's happening upon the people. Pretty simple. And it's looking at the study of populations in order to monitor the health of the population, to understand the determinants of health and diseases in populations. Why are things happening at certain places and not other places? Similar to the video that we all watched a couple of lectures back, if we're all people and basically we're all the same, why do some people have worse outcomes than others? Why do some people get some illnesses and not others? And also to investigate and evaluate interventions that prevent disease and maintain health. How do we measure whether our interventions are working or not, or helpful or not? So the main tasks for an epidemiologist is to study the distribution. Who's got it? Determinants. Why is this particular agent causing disease or not causing disease? And the dynamics. Why get it? Why some get it? Why some don't? And control. What to do to make it better? prevent it from happening altogether. And so epidemiologists really are detectives, looking at where is the source of this coming from and how can we make it better. So there's lots of terminology in epidemiology, and a lot of times they seem to overlap each other. Descriptive epidemiology, it seeks to describe the occurrence of disease in person, place, time. Who are the people? Where are they? And what time frame are we looking at? I think that's pretty simple. That's the kind of thing you guys hear on the news. The flu this past season was horrendous. It was the entire United States, but certain pockets started getting it sooner. That's the kind of thing that you hear all the time. Analytic epidemiology focuses on the investigation of causes and associations. What led to what? Was the incident person that spread it around, and how did that happen? Determinants are health events, are factors of exposures, behaviors, context, and characteristics that determine the patterns of why things happen, why diseases spread the way that they do. It can be individual, relational, social, communal, or environmental. So there's a lot of factors that play into that. An epidemic occurs when a rate of disease, injury, or other condition exceeds the usual or endemic level of that condition. So this past flu year is a perfect example. I happen to know this because I work on flu cases for the state of Georgia. We thought 2009 was the worst flu season that we had ever seen. It was higher than the normal flu season. And then we had this year. And for the state of Georgia already, in December, mid-December, we had already exceeded the number of positive flu cases that we had seen previously in the previous year. So what our normal level was, we exceeded that. And endemic is just the conditions that are normally present of agent or health condition in a given geographic area or location. So what's normal for your community? And it's different from place to place, even town to town. What is endemic to those areas can be different. We are here in the South. I know many of you came from other places. So here in the South, some of the things that are considered endemic, and you can think outside of infectious diseases, stroke, incidence of stroke is very high in the South for a lot of different factors. Other areas of the country, it might be heart disease. It might be diabetes. For example, the Native American Indian tribes that are in the western part of the country have a higher incidence of diabetes and alcoholism. We don't see that so much here. But those things are endemic to those areas depending on where you are geographically. And then, of course, a pandemic is an epidemic occurring over a widespread area, such as influenza this year. Very widespread. Multiple countries or continents are involved, and it affects a substantial portion of the population. Is it a lot? Are you guys good? Okay. So descriptive epidemiology looks at person, place, and time. What are the personal characteristics of interest to the epidemiologic event that's occurring? Race, ethnicity, sex, age, education, occupation, income related to socioeconomic status, marital status can affect things. And as noted previously, what's the most important predictor of overall mortality is age, right? The older you get, the more likely you're going to die. When looking at the distribution of a disease, geographical patterns come to mind as well. Does the rate of disease differ from one place to place? Do people in the South have more strokes than people in other places? The data shows that it does happen that way. In relation to time, epidemiologists ask these questions. Is there an increase or decrease in the frequency of the disease? Is it more common? Over time, are there temporal or spatial patterns evident? What's going on with temporal patterns is interest to epidemiologists, including secular trends, point epidemic. Is it just one point in place in time that we're having this outbreak? Cyclical patterns and event-related clusters. We see that a lot. Flu season is a perfect cyclical. It's not so prevalent in the summer here, and then we hit fall and winter and the flu presents itself. Kind of a side note, I have a friend who traveled to Australia. It was summer here. What is it in Australia? What do you think she got? She got the flu because she didn't get vaccinated for what was circulating there in that country. So those are the kinds of things that that sometimes you have to think about. If there's something happening other places in the world, is it something that can affect what's going on here? Another type of temporal pattern is non-simultaneous event-related clusters. These are patterns in which time is not measured. It's not a fixed date on the calendar, but from point of exposure or event, presumably experienced in common by affected people. So you go to an amusement park, someone there has something infectious, they have contact with that person. So it's not exactly occurring at the same time. Different people coming in contact with someone at different points in time throughout the day. They may get sick at different points, not all at the same time. So analytic epidemiology. This is mostly looking at cohort studies, case control studies, and cross-sectional studies. It searches for determinants of the patterns of, observed, the how and the why. How are these people getting ill or having health events, and why are they having health events? So a little quiz. I know it's a lot of information. So let's try to match up what type of epidemiologic concept is we're using for each of these particular descriptors. So the first one is this: ischemic heart and vascular disease is the #1 killer in Georgia from 2006 to 2015. It might be more than one. Y'all just say it out loud. Any guesses? What type of? Descriptive, right? Anything else? Could be. That's a good guess. How about determinant? Maybe. So it's also determinant because we're looking at other characteristics that determine or influence the patterns, how and why. How are people getting ischemic heart and vascular disease? Why is it the #1 killer? Right? We're looking at individual. Is it something with that individual person? Social, communal, environmental. Is there something that's going on that's causing this, for Georgia to have heart and vascular disease as the #1 killer? What are the things that are causing those factors to be at play? And this is why it's kind of like you're in the mud. How about the second one? Metro counties in Georgia have the lowest heart and vascular death rate in the state. So the metro area, thinking about metropolitan, the metropolitan statistical area of Atlanta, which is Fulton County, DeKalb County, Fulton, DeKalb, Clayton, Cobb. Am I missing one? Think about downtown Atlanta area, those counties. So it's definitely descriptive, right? We're describing what we're looking at. It's also distribution. Why is it distribution? Yes, limited to the metro area. The first one, we're looking at the distribution around the whole state, right? State of Georgia has vascular and heart disease, right?
Why wouldn't the first one also be distribution? Because like in America, like Georgia has higher rates of that.
It could be. It could be if you were looking at heart and vascular disease in the United States. Does that make sense? Okay. And so the last one, results from a case-controlled study show that River City children living in the urban district have 6 times the risk of presenting to the ED with asthma-like symptoms compared to non-urban children. Yeah, analytic.
Could that be distribution?
Determinant and distribution. I heard it. I heard all 3. Does it make sense why? Are y'all's brains about to explode? It's okay. It's all right.
Why isn't it descriptive?
Part of why it's not descriptive is because you're looking at, remember, descriptive is looking to describe the occurrence. So this is more analytic because it's looking at a specific area in comparison to another area. It does get kind of muddy in there because it does sound like it should be, right? It does sound like it should be. But it's not looking in terms of person, place, and time. All right. So the major conceptual frameworks for understanding epidemiology: natural history of disease, causation of disease, and levels of prevention. So natural history of disease. This is the process by which disease occurs and progresses in humans and involves the interaction of the agent, the host, and the environment, right? So the agent, what's making us ill? What's causing the problem? What is the cause of the event? The host. Is the host susceptible? You can be exposed to something, but if you're not susceptible to that for whatever reason, you have a great immune system, you don't have a cut on your body, you eat a healthy diet, you're not likely to get that. And then the environment plays a big role in the determinant of whether or not disease presents itself. So this is just another graphical representation of the epidemiologic triangle. I'm going to say that word so many times I'm going to mess it up, I just know it. So it just gives you a different visual representation of how it works. The environment really does play an important part in how things react to each other. Climate, whether it's hot, cold, rainy, dry, plant and animal life, what's in the environment, what kinds of things support good or bad things happening. The human population distribution, is it super crowded? Are people really spread out? How does that affect things that are happening? Socioeconomic factors, again, referencing back to the video that you all saw, what socioeconomic factors are preventing people from seeking care, from living in better environments, from being able to access and provide for better food, better nutrition. And then working conditions, stress level, noise levels, all of those things really affect what's going on with the host and the agent. Yep.
But the working conditions also include like exposure to chemicals or chemicals that
Absolutely, absolutely. So if you're living someplace where the only job is to work in the chemical factory, you're certainly getting exposed to things, not only at your job, but potentially in the environment. If pollution is being produced and then put out into the environment in which you live, then there's potential for exposure there as well. So again, the present model for epidemiology is based on the interaction of the agent, the host, and the environment. If there's an equilibrium, then it's a healthy community, right? This equilibrium, that's easy for me to say, that's when there's going to be a problem in the community. Perhaps the community, the population that lives in that community is genetically predisposed to a certain kind of condition. Perhaps they live in a place where there's a factory that produces chemicals which then pollutes their streams and soil around their homes where they live and play and work. In every disease, every condition has multiple factors relating to agent, host, and environment. They all interplay with each other. So again, just another representation. So I'm going to go through these next couple of slides a little quickly because I've kind of covered all this. But again, the agent factors, whether the agent is weak or virulent, what kind of physical conditions does it need to thrive, what type of chemical or biological agents are in place that help that agent survive. Is it a bacteria? Is it a virus? Lots of I always talk about influenza because it's the easiest one. Influenza doesn't like warm weather, does it? Likes cold weather. So that's when you're going to see it more. So that agent has a better environment in the wintertime. And again, control of some of these biological agents are accomplished through immunizations, can be prevented or lifespan shortened with antibiotics. But we're seeing more and more strains that are emerging that are resistant to antibiotics and other agents are increasing. So things to think about. Host factors. Age, again, the older you get, the more susceptible you might be to certain things. Women and men have differing factors that make them susceptible to certain things. Race, occupation, religion, ethnic group, culture, physique, marital status, birth order, all these things play into your host factors, whether you're susceptible or not. And I didn't find this little quote, but I like it. Genetics load the gun and environment pulls the trigger. So you might have something that is genetically an issue, but you don't know that until you go into an environment that allows all those components to come together and cause illness. One of my favorite little stories about that is the monks of Tibet. They live high up in the mountains, right? Think way, way high elevations, low oxygen pressure, but they're used to it, right? They've lived there for thousands of years. The Chinese government comes in, displaces them. They go to lower elevations in India. And one of the things that they has been a huge pandemic for them in that country, or epidemic for them in that country, is when they were forced to flee and go to lower elevations, suddenly the tuberculosis illness in that population exploded. They changed their environment because tuberculosis can't live at high elevations. They moved to lower elevation, changed their environment, and suddenly this entire culture, this entire population of people are now burdened with tuberculosis. So lots of things change when you change your environment. Again, favorable or unfavorable, lots of things go into that. The climate, vegetation, topography. Are you living in a mountain or are you living in a valley? What are you going to be exposed to? Animal bites. Some places have snakes. Some places don't have snakes. Or they have animals that are more likely to attack you. There's no tigers running around Atlanta. But you might get bit by a raccoon or a fox. Social, economic, and cultural factors. Again, same thing. Social class, urban versus rural, cultural, migrant. Are you moving from place to place? And then again, the environment changing. Not only are we moving to different environments, but the environment around us is changing. Let's see, is this my... Okay, so we can all do these together again. For the first one, death rates have been rising dramatically since 1999 among middle-aged white Americans. Is that the host, the agent, or the environment? Host, right. The cause, deaths of despair by suicide, drugs, and alcohol. And so what's the last one? Lack of steady, well-paying jobs? Environment, right. That's pretty easy. All right, so multiple causations of disease. So there's different models for looking at why disease happens. The first one, web of causality. It's a two-dimensional web that considers multiple level factors that affect health and disease. It kind of looks like a spider web if you think about different rings and all the things that can affect it. And so what might the spider be? So this was developed by Keeger, and he suggests that in addition to research on the relationships within the web, that we need to look at the spider. The focus of the larger factors and contexts that influence or create the causal web itself. So what makes all of those things fall into place that cause a negative event to occur? The ecologic model, this approach expands on the epidemiological studies that both upward to broader contexts, such as neighborhood characteristics, social characteristics, as well as downward to genetic and molecular level. So what's happening in the big picture, but also what's happening down at the individual level. So like the web of causality, it recognizes that multiple determinants of health are involved and treats them as interrelated and acting synergistically rather than just a list of factors. They all kind of intertwine and one affects the other. Another way of thinking of this is the ecologic model moves from a two-dimensional perspective to a multi-dimensional perspective. So you're looking at things from all different angles and all determinants, how they interact with each other. Which I just said. So we'll skip that slide. Let's see. So levels of prevention. How are we understanding how these agents affect us? So in the pre-pathogenic period, there's no disease. Everything seems to be interacting to produce stimulus for disease, or they may be acting to produce a stimulus for disease, making the host more susceptible. But at this point, there's no disease. And primary prevention measures are appropriate. Health promotion, immunizations, promoting exercise, healthy diet. So there's no disease at this point. During the pathogenic period, the reaction of the host to the stimulus from the interaction of the agent, host, and environment all occurs. And so this is early pathogenesis. So, for example, discernible early lesions, which progresses to advanced disease and then convalescent. During secondary prevention, it's early diagnosis and prompt treatment. So knowing what we're looking for and providing treatment to prevent disability. And then tertiary prevention is really just rehabilitation. We didn't catch it before it caused disease. We didn't catch it as the disease started. And now we're at the point where we're just trying to rehabilitate the host. Oh, well, I thought I was logged in. Let's see. So here's our first question, which y'all already saw. Oops. Well, it helps when you put the password where it's supposed to go, huh? Okay. Yay. All right, so here's our first poll. And y'all can change your answer if you want to. Which study model expands the epidemiologic studies both toward a broader context and downward to genetic and molecular level? I'll give y'all a couple seconds. What looks at the relationship of all the factors and how they interplay with each other, not only out to the community and the broader social aspects, but also down to the individual person. All right. All right, it's full. No more answers. So majority thought it was triangle model. Guess what? Ecologic model. Remember, the ecologic model is a big circle with the host in the center, right? So all the factors surrounding the host as they interact, as the host interacts with them and they interact with each other, it goes broader to the community and social aspects of the host and down to the individual level of genetics for that person, so down to the cellular level. Y'all quit changing your answers. I don't know who answered what, so it's okay. It's all right. Oh, there we go. There we go. All right. So does that make sense? Does that make a little better sense? So ecologic is looking at the host in the center, right? And then all of the factors that can affect what happens, the environment, the agent, social and economical status, the person's sex, health status, genetics. So it's the model that is going from the individual on the molecular level, all the things, bless you, all the way out to all the things that could affect that person. Does that make sense? The triangle is just, is the person susceptible? Is the agent able to make the host susceptible? Or is the environment helping the agent and hurting the host? Or helping the host and hurting the agent? So the triangle is a little more basic. Same question. Okay, so now the good stuff. Biostatistics and epiconcepts, good times. So we're going to look at proportions, rates, and risk, measures of incidence, prevalence, and prevalence rate, as well as comparing prevalence and incidence and mortality rates. All right. So proportion is used a lot when talking about statistics, which is just, if you don't understand basic math, you understand what a proportion is. So a lot of the rates that a lot of the things that we are talking about when we're looking at statistics and rates can also be described in proportion. So let's see. So for example, a survey of 85 students, summer of 2017, 59 reported preferring PowerPoint over any other forms of study aids. And so if you want to calculate the percentage of this group, you're going to take the numerator, 59 students, over the denominator, the total number, the total population, and divide it out and get 69%. So this is why the majority of the lectures are all on PowerPoint. Everybody seems to like that. So a rate is a measure of frequency of a health event that is in a defined population, usually in a specified period of time, and it measures how rapidly something is happening. So again, excuse me. So again, you're taking the frequency of what's happening in that population. You're taking the defined population that you've identified and looking at it over a specific period of time. Rates are used for morbidity and mortality rates. So for example, the 3-year infant mortality rate in Atlanta, DeKalb County is 13.1 per 1,000 live births. Make sense? Okay. So there's different types of rate. Morbidity rates look at disease. How often are we seeing this disease? And they can be made crude by cause. So what's the cause of MS? What's the cause of heart disease in this population? It can be more specific, looking at age, sex, race, people of age 25 with MS, women with MS, Hispanic women with MS who are 25 or younger. And then mortality rates look at death. How often is death occurring? It's important to write all the qualifiers when you're putting rates, when you're writing rates. If you just put a number out there without the qualifiers of who the population is, it doesn't always mean anything when you're looking at the bigger picture. So measures of disease burden, incidence, prevalence, and mortality. And one of the things also that's important about looking at infant mortality rates is infant mortality rates are used to look at the population of a country's health. When infant mortality rates are high, it's usually a very good indicator that the country's health overall is not that great. And we'll get to some slides of that here in just a minute. So that's why it's important to look at those rates. So incidence measures the occurrence of all new cases of disease in a specified time period. And it's determined through a cohort type study. So everyone is followed during a specific time period. The risk doesn't change during the follow-up period, and everyone has an equal risk of the event. So let me see if I can get this to work. We're going to look at a video, a short little video. So this is just a short video that gives a really good explanation of incidents. Maybe. Oh, hold on a second. I bet someone turned the sound off. Aha.
We were totally baffled as we saw the epidemic of heart disease.
Is that too loud? Okay.
We were totally baffled as we saw the epidemic of heart disease emerging really towards World War II. It was difficult to find heart disease in America before World War I. But gradually it moved into an epidemic proportion, and then people didn't quite know what to do. What is causing this disease? And then came World War II, the largest nutritional experiment ever conducted in the history of the world. What happened? As Nazi armies occupied the Central European and Northern European countries, they took all the livestock from the people. In these occupied countries now, the people had to live on very simple diets. They had to live on foods as grown. They had to live on foods without nutrition labels, simple foods, whole grains, fruits, and vegetables. They had to live on beans, simple foods that you grow in the gardens. And that's what these people had to do because it was wartime. And what happened? Within 1.5 years, coronary artery disease went way down in these countries. Diabetes went way down. Blood pressure rates went way down. Overweight went down. And all of a sudden, it was amazing to see heart disease dropping off virtually, in spite of the war and the stress and everything else. And so in America, we saw just the opposite. In America, we saw the heart disease rates going up and up and up during World War II. And we began to say, what could this be? And so this gave birth to one of the most important studies ever done, the Framingham study near Boston, which started in 1949. And they enrolled some 5,000 people in the town and followed them for the next 1, 2, 3 generations. And we learned the powerful lesson, and that is heart disease is not so much a genetic problem as it has to do with certain risk factors. It has to do with cholesterol, with smoking, with high blood pressure. It has to do with diabetes. It has to do with overweight, triglycerides, the blood fats. It has to do with stress and an inactive lifestyle. Of course, there are sometimes also some genetic factors, but these are the modifiable factors that we can change. And we learned from the Framingham study that heart disease was a disease of lifestyle. How people live, how people eat, largely determines how people die and when they die.
So kind of cool, huh? They didn't even, I'm sure that wasn't something that they expected was going to come out of World War II, right? It's a giant study. They looked at one population, 5,000 people, more or less, and followed them for 3 generations to come to this conclusion.
Why is that crossed out?
It's really not. I apologize. The slides had this preset background that couldn't be deleted, and I tried to adjust them, and I missed adjusting this one. So it's not really crossed out. It's a misplaced little fancy bar to make it look.
I got you.
Yeah, so it's not crossed out. So let's see.
I have a question.
Yeah.
I think a couple of classes ago we talked about how like the old model of public health was like it kind of blamed the individual for their own like health behavior, but the new model of health is that it's like the socioeconomic factors that is it those factors that contribute to the way that they choose to live their lives, or like the way that they like have to in a lot of scenarios.
Right. So it all kind of interacts with each other, right? If you had someone that was your twin, and they have done some twin studies on these kinds of things. You have someone that's your twin, and you grew up in this environment where, it's dry, you have plenty of sunshine, you have plenty of healthy food to eat, you have a low-stress job, you have a nice environment. Your twin grew up in some place where it's always wet and raining and the sun never shines, and it's difficult to have access to healthy foods or exercise. Those are factors that are going to affect what happens to you, but ultimately you still have choices to make. But yes, certainly socioeconomic status affects whether we can move out of that environment and have access to exercise and healthy food and health care, vaccinations, medicines, all those things. So the incidence proportion or risk is defined as a proportion of an initially disease-free population that develops disease, becomes injured, or dies during a specific, usually a limited period of time. So the persons in the numerator are those who develop disease, and all are included in the denominator, the entire population. So the Farmington study, they looked at 5,000 people. That's the entire population. That's their denominator. And then the persons who developed heart disease in that population, that's their numerator, and over a period of time. So they looked at 3 generations, so many, many years of time, to come up with the risk for that study, identifying the incidence proportion for heart disease. Did I go 2? No, I didn't. Okay, there we go. So the number of new cases of disease or injury during a specific time period over the size of the population. For example, 100 of the 189 diabetic men during a 13-year follow-up period, if we were to calculate the risk for these men, 100 deaths among diabetic men, what's your total population? 189 diabetic men, that's your total population that you're looking at, right? So you calculate their risk and come up with the risk of men dying from diabetes in the study is 52.9%. Does that make sense? All right. So again, the incident rate is the total number of new cases over a total person time of the population at risk during that period. So an incident rate of heart disease among Americans is 2.6 per 1,000 person years. So what does that translate to? It's 2.6 new cases of heart disease per 1,000 people per year. And you'll see it written as person years quite frequently in when literature search in research. So prevalence measures all new and old cases in a population during a specified time. It depends on the incidence and duration of the disease. What are you looking at? It can be determined through a cross-sectional study. It can be used by health planners to measure the need for treatment and for facilities for that treatment. Can you guys think of anything that a prevalence rate would be important? I'm sorry? New disease breakout, yeah. What else? What do we look at? What do you hear in the news? Just shout it out. How many people die from what? Right, so for example, what's the prevalence of heart disease? Or what is the prevalence of death related to a new drug? What's the prevalence of healthcare associated infections in long-term care facilities? So there are lots of things that go into the prevalence pot. And prevalence helps with looking at rates as well. So prevalence can change based on incidence, immigration. Are there new people coming into an area that are more susceptible, or are they bringing it with them? And also deaths and immigration, people moving away from areas. Are they taking it with them? Are they taking their risk factors with them? One thing to remember, though, is a decrease in prevalence may be due to a decrease in incidence from a vaccine or prevention that's been put into place. So you might have a high prevalence of measles, for example, in an area, and then the health department comes in and vaccinates everybody, and then the prevalence rate drops. Prevalence can stay the same, but it looks like it's the same, but it's due to a decrease in death rates despite the incidence. So you might see a kind of plateaus where if you have an incident rate, people aren't dying from it as frequently, and so the prevalence stays the same. So again, prevalence is all new and pre-existing cases during a given time period, and looking at the population of the same time period. So for example, all the patients in this hospital that had a bloodstream infection in the month of July over the entire population of that facility. That's how we determine what the prevalence of bloodstream infections in that facility are. So mortality is a ratio of the total number of deaths to the total number of people at risk of dying during a specified time period. So again, it's a measure of risk. It's measured using cohort study design, and there's accrued mortality rate, which is the total number of deaths over the total population at risk for the specified time period. And there's also a proportionate mortality rate, which is the number of deaths from a specific cause over the total number of deaths during that specific time period. Ooh. And again, as I said, infant mortality rates really show the health of a nation, how we're doing as a nation. And it's used as a rate to indicate the overall health of the community. It's a total number of deaths of children under the age of 1 divided by the total number of live births in the same year. So your total denominator population is how many babies were born in this country this year. And your numerator is the total number of deaths of children under the age of 1. So how do y'all think the United States fares?
Really badly. Like almost.
You guys are like paying attention. Yay. Somewhere else, because I know you hadn't, I don't think you guys have heard it here yet. So this is from a couple of years ago, but this is the infant mortality rate for DeKalb County. What county are we in? DeKalb County. So as you can see, the darker brown areas have the highest average infant mortality rate per 1,000 live births. So in areas in the western part of the county, 12 to 14 infants die for every 1,000 live births. That's a lot of babies, y'all. That's a lot of babies. And you can see on the map on the y'all's right side, there's little pockets where it seems to be better. Where do you think those pockets are? For those of you that aren't from here, so Dunwoody is a more affluent area. There's lots of million-dollar homes in Dunwoody. They have a 2.6 per 1,000 live birth rate. So you can see quite starkly on this map how we do here in DeKalb County based on socioeconomic. You can see where socioeconomic status affects infant mortality rates. Of course, there's other factors as well. Here's the United States right down there at the bottom next to Cuba. Doesn't seem so good. It makes you want to go live in Singapore, right? If you're going to have a baby. And some of these other countries, we don't think of as being the best place in the world to have a baby, right? We live in America. We don't think of as Singapore as being the best place to have a baby, but they have the lowest infant mortality rate in 2000. It actually hasn't changed much to today. This was in 2005. We're still down there at the bottom. Singapore's still at the top. Y'all are young. You might want to go to Singapore, have a baby when you're ready. 2007, yeah, we're still down there at the bottom. Not so great. It seems kind of ironic, doesn't it? We live in the wealthiest country, supposedly the wealthiest country in the world, and yet we can't keep our babies alive. What's up with that? It's been an ongoing issue. So rates can be a bit misleading when you're looking at different populations. So, for example, the risk of death increases dramatically after age 40. Therefore, a higher crude death rate is expected from a population of older people. That makes sense, right? The closer you get to 80, the more likely you are to die. But if you're 20, 23, 25, we're not expecting you to have a high death rate. So there's two methods for looking at age-adjusted risk assessment. So the direct method is a direct age-adjusted rate that applies to the age-specific death rates from a study of population to the age distribution of the standard population. So the result is that the hypothetical death rate of the study population, if it had the same age distribution as the standard population. I know, it's clear as mud, right? There's no test on this, just remember that. So indirectly, it's a little more complicated. The age-specific death rates of the standard population is applied to the study population, and the distributions produce an index rate that is used with the crude rate of both the study and the standard populations to produce a final indirect adjusted rate. The main thing that y'all need to know is that when you're looking at different ages of a population, that there is a calculation to adjust for age when you're looking at a population that spans many generations. That's really the most important thing to take away. So ratios are also used a lot. Again, kind of basic math. It's just knowing how things get interpreted. So Delaware's infant mortality rate in 2001 was 10.7 per 1,000 live births. And in 2001, the mortality rate was 3.8 per 1,000 for live births in New Hampshire, right? So what's the ratio of infant mortality rate in Delaware to that of New Hampshire? So again, comparing one state's infant mortality rate to another state's infant mortality rate. So numerator is going to be 10.7. The population that we're looking at divided by 3.8, the population we want to compare to. So Delaware's infant mortality rate was 2.8 times as high as New Hampshire's for infant mortality rate in 2001. So the relative risk ratio is a morbidity measure. It's not a rate. And the measure of incidence risk of exposed group versus an unexposed group. So the risk is the same for both groups, right? Whether you might get exposed or not. And a ratio greater than 1.0 indicates a greater risk for the exposed group. So an incident in the exposed group over the incidence of the unexposed group. Yeah. Uh-huh. I'm sorry?
Like you multiply by 1 after the 10.7 over 328. Was that the 10 to the n? Or what's that multiplied by 1 for?
That's a good question.
Doesn't it just stand for the fact that it's supposed to be a 1 ratio?
Right. Right. No, you're right, because it's comparing 1 to 1. Does that make sense? Yeah, okay. And so applications for epidemiology. So I know at the beginning of this course, it was talked about, how is public health nursing, how is community nursing, how is that going to apply to me? I'm not planning on doing this or becoming a public health nurse or working at the health department. But it's community-oriented epidemiology. So involves observation, data collection, consultation, and interpretation. So, you may be a nurse practitioner working in a clinic and make observations and say, well, why is my population of people getting a certain illness? And Lillian Mood was a public health nurse that in South Carolina. She'd been a public health nurse for over 20 years. And she was working with communities to detect and explain causes of illness and disability in her population, which is where she worked. And in describing her involvement with specific communities, she noted that contact often began with a telephone call of concern about a planned or existing industrial facility that was being planned for that area. And she had firsthand observation of illness from her patients who were expressing that there were just too many cases of cancer for in their family, in their communities, and their friends. And so the citizens reasoned behind these observations that if they're seeing more health problems in my community, you have to ask, what do they all have in common? Why are all these people getting sick when there wasn't an issue before? So, it must be something. It must be something in the air. It must be something in the water. It must be something that this factory that's now being built has caused a problem. And so this is just basic epidemiological thinking that why is something happening now that didn't happen before? And so this is really kind of termed popular epidemiology. It's when you see things that are happening in your community that you haven't seen before, and you're wanting to know why this is happening. And you might have that experience in your practice where you're a nurse practitioner in a clinic and you've been there for 5-10 years and you've not had any issue with high population of people coming in with, say, hypertension, and then all of a sudden it seems like every other patient every day has hypertension. You might say to yourself, what's going on in my community? Why all of a sudden are we having this issue? So that's probably the best application that, when you're out practicing, as things change over time, you're going to notice those changes and ask yourself, why is this happening? All right. Let's, are y'all ready for a break? I am. Yeah? Okay. Let's take about a 15-minute break. We'll come back at 11:30. Yeah?
Before you all leave, if you wouldn't mind going into your Canvas course site, well, you can do that after the break as well, but if you could fill out that evaluation.
I promise this will be a little more exciting than statistics and math. So I think this is a very good quote from Dr. Heyman, even though it's from 2001. I think everybody here is familiar with the Ebola events that happened a few years ago and the kind of pandemonium that happened around that. But the truth is that diseases don't have respect for borders. They don't know what borders are. They come and go wherever they please. So that's just something to think about when we think about diseases, especially infectious diseases that are highly transmissible. So again, the objectives for this section, looking at principles involved in disease transmission, which we went over somewhat in the first section, how they interact to cause infectious diseases, characteristics of modes of transmission, and prevention of infectious diseases, trends for certain epidemiological significant illnesses, diseases, HIV, STD, hepatitis, and TB. Those are illnesses, diseases that you guys will be hearing about over and over again throughout the course of your education and your careers. Public health and preventing and protecting against vaccine-preventable diseases, and nursing considerations for identifying, preventing, and controlling infectious diseases. So infectious disease are diseases that are caused by a biological agent, usually a virus, bacteria, fungi, or parasite, although there are others. They're transmitted sometimes vertically, which is from mother to child, or horizontally from person to person. Vertical transmission can also be if a man has an illness that is then given to the woman through sexual activity and then transmitted to the baby. Is also considered vertical transmission. And it occurs through multiple routes, direct or indirect contact, common vehicles such as food or water, airborne or vector-borne. We've already discussed the definition of epidemiology of how we're looking at the distribution and determinants of health-related states in specified populations. So again, epidemiologic triangle, how the host, agent, and environment all interact to support or suppress infection or illness. Now, the chain of transmission is very important when we're talking about infectious diseases. Not only do you have to have a susceptible host, the organism has to have or the agent has to have a way of entering the host. There has to be a reservoir. Where does it live when it's not actively infecting somebody else? And then how does it get from point A to point B? And any break in this chain can prevent disease or illness. So infectious diseases cover a lot of things. Animal-related diseases, insect-related diseases, sexually transmitted diseases. There are infections that have become drug-resistant. There's vaccine-preventable diseases, water-related diseases. There are so many different ways for different organisms to be transmitted, and each organism has its own specified route of transmission. So again, looking at the disease spectrum in the community, an endemic is something that's constantly present within a geographic area or population. So, for example, pertussis has become endemic in the United States. Dengue fever is not endemic here, but it is in Africa. An epidemic is an occurrence of disease outside, in the community, outside the normal expected. So, for example, seasonal flu can be an epidemic. This past flu season was an epidemic. It was outside our normal number of usual flu cases for a season. Oh, I apologize. Y'all should have told me to put my microphone back on. Am I talking really loud now? Or are y'all just asleep now? Is that better? That's much better. Okay. Pandemic is new and sometimes previously unrecognized pathogen that spreads worldwide and has high incidence of morbidity and mortality. So recent pandemics would be the H1N1 flu in 2009, as well as SARS outbreak that happened previously. As Dr. Frieden, who is the former director of the CDC, has said, a risk anywhere can be a risk everywhere in hours. And again, Ebola, everyone was terrified someone was going to get on a plane and come here and bring it, which did happen. We were able to contain it. So, let me see. All right, we're going to do another poll. Y'all ready? A nurse working at the hospital attends to a 10-year-old boy with complaints of fever, headache, neck pain, and stiffness. After running several tests, the team treating the child diagnoses him with polio. The nurse understands that polio in the United States, oh my gosh, y'all, are there only 3 people answering? So think about polio. Polio has been eradicated in the United States, right? So it's not endemic. It's not endemic. There we go. It's not endemic to the United States. Epidemic. That's correct. Show the answer. Epidemic. So some diseases, you don't have to have 500 cases or 50 cases for it to be considered an epidemic. If it's an illness or disease that's not endemic to an area, then one case, such as polio, is considered an epidemic. Yes?
But I thought epidemic is if it's in more than it's than used to. So just having one case is more than normal?
Yes. Yes. So in the United States, polio has been eradicated. So there have not been any cases of polio in years and years. So if one case of polio shows up, that's more than normal. Normal is 0, right? But we know polio is highly infectious, so one case is considered an epidemic.
So then how come seasonal flu is not an endemic? Because if it's constantly
Seasonal
there.
flu is endemic, but there are years when it is epidemic.
Oh, okay.
So, for example, last year, say we had 1,000 flu cases in the United States. That's not an actual number, but just let's pretend we had 1,000 in the United States, right? And so this year, we had 30,000. That's way above the normal. So last year, flu was endemic. This year, flu is epidemic because the normal number of cases that were expected was exceeded. Does that make sense? Everybody got that? The point here is just that there are illnesses that one case can be considered an epidemic because it's not endemic to an area. So one case can be epidemic. And like you said, flu sometimes fluctuates. Some years are just normal years, and it is endemic to the United States. And then other years, we see a high rate of positive flu tests, and those years are considered epidemic years. All right, so let's talk a little bit about immunization. I know sometimes this topic can be polarizing for people or very strong opinions about vaccines or not getting vaccines. However, they are among the most cost-effective preventative service that public health has ever had available for populations. They're a very high return on investment. It's much less expensive to vaccinate people than it is to treat them once they become ill from an illness that can be prevented from vaccines. The example here, for each birth cohort vaccinated, with a routine immunization schedule, we save about 33,000 lives, prevents 14 million cases of disease, reduces direct health care costs by $9.9 billion, and saves about $33 billion in indirect costs with lost wages, lost productivity, etc.
How large is a
Dr. Fan? For this example, for the birth cohort vaccinated, is that for live births for 1 calendar year? I would assume, yeah, stump the teachers, right? I would assume that the birth cohort is the number of live births for 1 calendar year. The bottom line is vaccines are cheap, and they save society money in healthcare costs and indirect costs, as I said, such as lost wages and lost productivity. So the CDC publishes every year a vaccination schedule. There's schedules for childhood from birth to 6 years, adolescents 7 to 18, and then catch-up schedules and adult vaccination schedules. Many of you, when you register to come to university, were probably required to look at your vaccination history and provide that information to the registrar. And those vaccine schedules do get updated every year. And then here in Georgia, we have what we call GRITS. And it's the web-based program for storing individuals' immunization records from birth to death. It is mandatory if you provide vaccines, you have to document in the GRIT system or have someone document the information for that individual in the GRIT system. And this helps, identify people who have gaps in vaccination history and also prevents people from getting over-vaccinated, getting second and third vaccinations of things that they don't need. So the irony of vaccine successes. So for all of us, how many of you had somebody you knew growing up that had chicken pox? Oh, actually a couple people. That's actually a surprise. I've asked that question in different groups before and with younger generations, and maybe 2 or 3 people raised their hands. A lot of that's because we have a vaccine for chickenpox now. And so the problem is many of these diseases, smallpox, measles, meningitis, people have a false sense of security because they haven't seen these illnesses. They don't remember how sick people, children mostly, children have become from these illnesses and have died from these illnesses. So in the absence of seeing that disease, parents think there's no risk of their children getting ill. They start focusing on adverse reactions to vaccines instead of the benefits of the vaccine, and start to have this false idea that vaccines are more dangerous or a greater risk than the disease itself. So this graphic is a little dated. It's diseases compared from the early 1900s to 2010. But I think that it really shows the comparison of the early 1900s when we didn't have vaccines and the number of people children that became ill from vaccines. The measles is the giant. Does this one have a pointer too? Oh, it does. So the yellow on the 1900 side, this is measles. The cases of measles in the early 1900s was 530,000 children got infected with measles. And in 2010, there were 61. Pertussis, while it's still prevalent, there were 200,000 children that developed pertussis in the early 1900s, and in 2010 there were 21,291. And there are a lot of these other illnesses, such as polio. Because we don't see polio in the United States anymore. It is still a disease of concern in other countries, but we don't see polio here. And at the turn of the century, 1900s, there were about 16,000 children diagnosed with polio. Yeah.
Why do we still vaccinate for things that aren't prevalent anymore, like polio? Like it says that, like diphtheria, for example.
Right.
And it's 0
Right.
prevalence rate. So why is it that we still have to get those vaccines if there's like, you know, herd immunity and stuff like that?
Right, so we still vaccinate children against those diseases that are considered eradicated because we have become a very global society, and it only takes, for example, polio, it only takes one person who's not vaccinated to travel to a country where it's endemic to contract polio and bring it back to the United States.
So unless it's eradicated worldwide, because like smallpox, isn't that eradicated?
And we don't vaccinate against smallpox. There are certain populations like military and whatnot that do get vaccinated, but in the general population, we no longer vaccinate for smallpox.
So I don't get why we don't do smallpox, but we do the, like, other, you know what I mean?
Well, and smallpox is not as endemic in the world as it had been previously. I don't know of any smallpox cases, so worldwide, but there are still polio cases. You can travel to other countries and still get polio. Sir? Okay. Right, yeah, smallpox has been eradicated worldwide, so, but the other illnesses are still endemic in many areas throughout the world. So measles, because of this lack of vaccination in certain populations, in 2014 we had the greatest number of measles since it was declared eliminated in the United States. And this particular case was actually spanned from 2014 to 2015. You all may have heard about it. It was in the news. They never identified the indexed person. But they believe this person had traveled to a country that they were not vaccinated, had traveled to a country where measles is endemic, and then came to the United States and visited Disney World in California. And so they ended up that year with, as you see, a multi-state outbreak of measles, and a good majority of the people who became ill with measles had never been vaccinated. And these are children. You have to remember, especially for measles, we're talking about children, right? We're not talking about grown-ups. We're talking about children who had gotten measles. The picture in the lower right-hand corner there is a stock photo of a child with measles. They have that rash over their entire body, and fever and cough, it's imagine having a rash on your body from head to toe, and being a baby, being a little kid. Yeah, like chickenpox. It's not fun. Pertussis has also been on the rise in the United States, and there's a number of reasons for that. One is lack of vaccination. The other is that they have looked over a long period of time, and they have found that vaccination for pertussis wanes as children grow older. They actually, a few years ago, made a change in the recommendation and now recommend that older school-age children in the, I think it's 7 to 17 age range, middle to high school range, get a booster for pertussis. They also recommend that adults who are having babies who have not had a booster, that not only they get a booster for pertussis, but their parents get a booster for pertussis. There were a lot of cases where the grandparents were ill with pertussis and didn't know it. Family brings newborn baby home who's never been vaccinated. They have to be at least 6 months of age before they can start their vaccinations for pertussis. And these newborn babies were getting pertussis, and some of the babies died. So they found that vaccinating older adults with boosters helps protect those populations that can't protect themselves. Mm-hmm.
What's the role of schools with like vaccinations? Because don't schools require vaccinations?
Right, so that's a whole other sticky subject. But yes, most schools in the United States require vaccination in order to attend school there. And every county has school district has their own policies, but generally they are required to have vaccinations in order to attend school. As I pointed out, for you all to register for a university, you had to probably had to provide your vaccine information. I know I did.
Do you know if it's routine for schools to offer religious or personal reasons to refuse vaccination?
It depends on each school. I don't know how. I'm not a school nurse, so I'm not sure how that works. But I do know that there are provisions just about everywhere now that if you have a legitimate religious exclusion, that they will honor that. But again, it depends on school to school.
So in the decrease in vaccinations, that's primarily people's choices not to vaccinate, not like a lack of access.
Correct. Well, there is sometimes a lack of access. If you live in an area where you don't have a clinic that you can go to, or you can't afford to go to the doctor, that certainly can be a factor. But also, all of these vaccines are available through county health services. So if you aren't able to afford to go to a physician, you can go to your county health department and get all your childhood vaccines for low or no cost. So again, just because these are kinds of diseases that people are not used to experiencing, I'm going to show you. Well, first I'm going to show you this. This is kind of funny. Like I said, it's very polarizing. Everybody has different opinions about getting vaccinated or not getting vaccinated, but I thought this was kind of humorous. So this is how anti-vaxxers sound to normal people.
Oh, that's not sunblock, Mandy. Oh, no. That's poison for your skin.
Just because you give your children pants, that doesn't mean it's the right decision for everybody.
I don't believe in microwaves. My son used one and now he's gay.
Wait. Aren't you afraid of how many toxins are in that?
It's water.
Yeah, bottles.
You would know. No way. Like 1% of the population has a latex allergy. I could have a latex allergy. Don't be so selfish.
I'm gonna call the fire department. No, don't worry. It'll burn itself out. Alright? This is my property. I decide what happens to it.
Yeah, but you spread to other homes.
Yeah, well then I'm doing them a favor. Alright? Every home needs to learn how to burn.
Rhonda, thank you so much for throwing this amazing wild bear party. I mean, I just wanted to get it out of the way for my kids, you know?
We need a doctor. Is anybody here a doctor?
What's the problem?
Oh, thank God. Doctor, my wife is going into labor.
Full disclosure, I'm not a doctor, okay, but I did all the online research. I am basically web certified.
I just read so many posts about the danger of windshield wipers online. It hardly rains in LA anyway.
I stopped giving my kids salads because there's no evidence that says that salads don't lead to obesity.
Thanks so much for watching.
So, pretty funny. And then this next video that I'm going to show you is, let me see. Yeah. So the next video that I'm going to show you, this is a child, this is a young child with pertussis. And this is what people are not used, this is one example of how people are not used to hearing and seeing these diseases. And that sound where she's sucking in air, that's a characteristic whoop or whooping cough. That's how pertussis got the name whooping cough. Yeah, cough until she throws up because she can't get air and she can't stop coughing.
How do you treat
antibiotics or prevent it with a vaccine. But pertussis can be persistent for months. I actually have had pertussis. I was sick for 3 months. I coughed like this for the first month. It was pretty bad. And I've been vaccinated, but I was outside of that window of. And you can see this video goes on for 2 minutes. She continues to cough like that for 2 minutes. Imagine if you had to cough for 2 minutes and you couldn't catch your breath. Many patients with pertussis turn blue because they can't get in air. Every time they take in an air, it triggers them to cough. And they suck in air and it triggers them to cough. So it's exhausting disease. Exhausting disease. Go ahead.
For chickenpox, was that something like that was deadly? Is that why they came up with a vaccine? Because it seems like now, I don't see why.
So again, chickenpox was very widespread. One of the things that the joke in the I'm so glad you had this bear party. When I was growing up, people used to have chickenpox parties because there was no vaccine, and the best way to get your kid over it is to have them get chickenpox. Also, getting chickenpox as an adult is 10 times worse than when you're a child. So it can be very devastating. It's usually mild disease in children, but it can be very devastating in older populations.
I have a question. So for the chickenpox, I had the chickenpox vaccine as a kid, and I got like the booster in elementary school or high school or something. But then like when I had to get the titers drawn to come here, like I'm no longer immune to it, but it's not recommended to get the vaccine for a third time. Like why wouldn't they recommend like the CDC? Like,
I don't know. I'm not a vaccine expert, so I'm not sure why they might not recommend another booster.
Like, what's the point of getting it if it's going to run out?
Well, but it still protects you from getting that disease during the highest prevalence time, which is during childhood. So, somebody else have a question? No. Yep.
So this kid, she had whooping cough, got treated, right? Can she still get the vaccine so she doesn't get it again?
Yes. That you.
Will it be as effective?
It should be, yeah, absolutely. I mean, it's just like, so when you get chickenpox, you can have chickenpox as a child, and the virus goes dormant, and then later in life, as an older adult, usually 65 or older, you can develop shingles. But you can still get a shingles vaccine to prevent that from happening. So it would be just like getting a booster for chickenpox. And I'm not sure why they might not recommend a booster for chickenpox if you've had it. And your titer doesn't show that you had an immune response to that. I'm not really sure why they wouldn't recommend that. So influenza. Influenza is endemic worldwide, as we talked about previously. There was a pandemic novel influenza strain, H1N1, that circulated in 2009. The virus was originally caused outbreaks in pigs. Animals get influenza as well. So part of the reason why in 2009 it ended up being a pandemic was because there was little to no immunity in the human population. Nobody had really been exposed to it before. So that's why it had become a pandemic. We've also heard about the avian flu, H5N1. This is an influenza A virus that's chiefly found in birds, but human infections have been reported, mostly those who work with birds, poultry, but the risk of contracting is generally low. And human-to-human transmission is rare, so they still keep an eye out, but they don't find that to be circulating within the human population worldwide. But vaccination is still very important, and nurses' role in vaccination, administration, and education is also important for our populations. We help recommend and reinforce the benefit and risk of vaccines and diseases. It's important to stay up to date on research that's available and the schedules and administration records. Like I said, the CDC updates those records, or those administration records every year. making sure that there's proper timing and dosing between vaccinations. They do have some extended vaccination schedules that if you are not, your patient is not comfortable, their parent is not comfortable with having so many vaccines at a time, you can spread them out. They have a schedule for that. Understanding the precautions and contraindications for vaccine administration. There are special population groups that vaccines can be highly recommended for, or it may not be recommended for, depending on what their particular situation is. Making sure that you're using GRITs to document so that, again, it's mandated in the state of Georgia that anyone who administers vaccines enters that data into the GRITs online system, and that all vaccines that are administered have dates with them in their medical record as well. And then managing side effects and reporting of suspected side effects through the Vaccine Adverse Event Reporting System. This is a national reporting system that providers can report side effects or suspected side effects from vaccines. Again, it's collecting data so that they can look at it from an epidemiologic perspective and say what's happening with this vaccine or this illness that we might need to take another look at. Let's see. Oh, is this the... Do I have another video for you guys? Oh, I think that was the one that I just showed you. Okay. So let's talk a little bit about prevention of infectious disease. So universal precautions or standard precautions. Have you all heard about universal precautions or standard precautions already? Right? Okay, so this is going to be a brief overview. So of course, that PPE, you're going to use that whenever you anticipate contact with blood or any body fluids that might have blood in it, whether it's visible or not. Sweat has not ever been determined to be a transmitter of any kind of illness, so we don't worry about that. But hand hygiene is the cornerstone of prevention. You've probably heard that, and you'll hear it a million times more. Gloves, wearing a mask or eye protection, face shield if you deem necessary, gowns if you feel necessary, and universal or standard precautions also deals with proper handling of sharps such as needles, scalpels, and proper disposal. So not recapping needles once you've given an injection or activating the protection, the sharp protection system that are on injectables, and disposing of those properly and quickly in a sharps container. And I like to think that also part of universal or standard precautions is when you see someone who's not using them properly, making sure that you approach them in a tactful way and maybe offer them assistance in using PPE as needed. We also have transmission-based precautions, which is in addition to standard precautions. Whatever facility you're in, you're going to want to follow their policies and procedures. Almost every facility that I have ever dealt with has some sort of signage on the facility door or on the patient room door, so that those who are coming in contact with that patient understand that there are additional precautions they need to take on top of standard precautions. Contact precaution is gloves, gown, and hand hygiene. The most common examples would be patients that have MRSA or methicillin-resistant Staph aureus, Clostridium difficile infections, norovirus, any kind of draining abscesses. Droplet is when you wear a surgical mask when you're within 3 feet of the patient, 6 feet for smallpox. Again, smallpox is not relevant really for our populations. And hand hygiene. So influenza, pertussis, meningococcal diseases, you want to make sure you're wearing a surgical mask. And then airborne precautions. Everyone here is fit tested for an N95 respirator, right? Not yet, but you're going to, right? Okay. So getting fit tested for an N95 respirator, and it is different than a surgical mask. It is a respirator. And one of the things that I think is important for you all to know is the difference between a respirator and a surgical mask. a surgical mask keeps the germs in, right? You think of going into surgery, I don't want the germs in my respiratory tract going to that patient. So the surgical mask for droplet, it keeps the droplets right here with the patient, right? The N95 respirator, it protects airborne particles from getting out into the air and floating up on the air currents and potentially infecting somebody else. So the respirator filters the air that you breathe in so that you don't get exposed to those particles. So patients that require airborne, for you to wear an N95 respirator for airborne precautions, those patients also have to be placed in a negative pressure room. And that is to prevent those airborne particles from going out into the rest of the facility. If the patient is coughing and you feel like they need to have some sort of transmission-based precautions, you put a surgical mask on them, keeps their germs right here with them. Tuberculosis is the #1 thing that you'll see that you'll require an airborne respirator for, an N95 respirator for, and also measles and SARS. Does somebody have a question over here?
I was going to ask, why do some populations wear a mask if the germs are, it's sort of their germs?
I have no idea. I mean, people, and sometimes it's a cultural thing too, and I'm not really sure why that is. But wearing a surgical mask, while it might protect you from splashes, it's not going to necessarily, it might help filter some of those things out, but it's not necessarily going to protect you from airborne illnesses. Mm-hmm.
I've talked to people who wear them, and they feel like if they're getting sick, especially in really high population areas like China, for example, with 20 million people, they do it as courtesy for everyone around them if they feel like they're not very healthy.
Oh, good. That's good to know. I had no idea. Mm-hmm.
And also, I know that at certain healthcare facilities, like nursing homes and things, like if the nurse did not get their flu shot for whatever reason, they wear them so that they don't put the
residents at risk. Yeah, that's absolutely true. Some facilities have mandated influenza vaccination, and if you choose not to get vaccinated, then you're mandated to wear a mask to protect others who are potentially immunocompromised. And I always think of anybody who's in a healthcare facility as being somewhat immunocompromised because they wouldn't be there if they were healthy, right? So.
My best friend is studying abroad in South Korea right now, and she's worn the surgical mask outside in Seoul because the pollution there is so bad that it hurts to breathe sometimes.
Yeah. And people do that. She might be better off with an N95 respirator because that actually filters the air. But a surgical mask definitely can provide some protection, but it's not going to save you from airborne illnesses. So, oh, somebody already answered this. Let me clear it. Let's see. Okay. Oops. Go back. All right. Are y'all ready for this? Nursing student, clinical rotation assigned to the surgical floor. His patient of the day is post-appendectomy patient. I didn't even read the question. You guys got it right. So the nursing student did not see any diseases listed on the patient's medical chart, but they know they must observe universal or standard precautions because blood and body fluids need to be handled infectious. And yes, hospitals are reservoirs for infection, but the correct answer is blood and body fluids. That's right. It's kind of a joke, right? People go to the hospital to get better, but it's not always the best place to go to get better. So emerging infectious diseases are diseases which the incidence has increased in the past several decades or has potential to increase in the future. So again, killer virus, Ebola, Zika virus is now come to the United States in the last few years, and again, the flu season this past year was incredible, the number of positive cases. So just for the sake of time, I'm going to skip this little exercise because I think that you guys kind of get this. TB, 1/3 of the world's population harbors tuberculosis. is at risk for developing active disease. So tuberculosis is kind of unique in that you can have latent tuberculosis TB infection. So you can be exposed and be infected with the bacterium and never have any signs and symptoms and not be contagious to anyone. And you can live 20, 30 years and not have any problem with it. TB disease is when it progresses to symptoms and becoming infectious to others. It is transmitted via airborne. The particles are 0.5 micron. They're very tiny, and they float up on the airwaves. And they literally, like when you shake a curtain or move something and you see the dust particles floating in the air, tuberculosis can be one of those little particles floating on the air. It's diagnosed through the Mantoux skin test. Many of you probably have received it. Also chest x-ray or a blood test. And it's very high prevalence in HIV infected persons, again, because of their decreased immunity. It's also very prevalent in poor urban areas where there's lots of overcrowding and in closed areas where people are breathing each other's air. Once inhaled, the bacteria travels to the lung and establishes infection. It's about 8 to 10 weeks after an infection that the immune response limits the activity of the bacilla, and it's detected by positive testing. Some bacteria survive and remain dormant, but can be viable for years. Like I was saying, they can go through many, many years of not having any illness. But some people who have this infection also will take prophylactic therapy just to prevent them from developing active disease, especially if they're a high-risk population. And 5 to 10% of persons with untreated latent tuberculosis will develop active disease sometime during their lifetime. So if they're a high-risk person, they would be getting treatment even though they don't have active disease. I'm not going to show the little video, but y'all can look at it. It's kind of cool how it shows how the bacterium enters the lungs and invades the tissue. So the treatment is very lengthy, 6 to 9 months taking medication. And it must contain multiple drugs. There are 10 that are FDA approved, but 4 are the most common drugs. And resistant tuberculosis is on the rise. Some of that's from treatment failure because the patient only chooses to take one medication, or in other parts of the world, more than one medication may not be available, or they choose not to take the medication or not the full course of it. 6 to 9 months is a long time to be on a medication. And in the United States and other parts of the world, there is mandated direct observation therapy for certain groups. And that's literally a nurse going to the person's home, giving them the medication and watching them take it. Unfortunately, that it does happen because of resistant tuberculosis. We're trying to prevent that from happening. So tuberculosis cases in the United States have gone down since the early 80s. But resistant tuberculosis still is a problem. So this is a graph showing primary multi-drug resistant TB. And as you can see, it has gone down over the years, but we still see a large percentage of cases that occur in the United States. Again, a lot of that is from people who start the medication and don't finish it or don't finish the full course of it. So HIV/AIDS, the number of people in the U.S. living with HIV or AIDS is about 1.1 million people. The primary infection lasts a few weeks. It's mild signs or symptoms. A lot of times people think they have mono, and they won't test positive during this time period. There's a clinical latency where patients can have no symptoms. That can sometimes last for years, and then transitions to symptomatic disease, which is AIDS. There are antiretroviral medications that slow the progression. There's pre-exposure prophylaxis for very high-risk people, men who have sex with men, people who are IV drug users, people who have sex with men who have sex with men who are also IV drug users. You can take pre-exposure prophylaxis. And then there's post-exposure prophylaxis for emergency situations. If you find out you got exposed through maybe a needle stick, splash, you can have post-exposure prophylaxis when you've been exposed to blood or body fluids of a known HIV carrier. Modes of transmission: sexual contact, IV drug use, perinatal, so vertical, it can be transmitted from mom to baby, or other exposures to contaminated blood or body fluids. It's diagnosed with a blood test. A lot of people opt out of testing due to fear and stigma of HIV. It's better now than it has been, but there's still a lot of fear surrounding HIV and AIDS, even though people have been living longer, the treatments are better, and people are able to live with HIV not progressing to AIDS for years and years. And this is just a little infographic showing the estimated new HIV infections in the United States by transmission category. People often think of AIDS as being something that is a disease of gay men and bisexual men, but it also is very prevalent in the heterosexual community as well. People don't often think about that. And I think the interesting thing, 1 in 7 people are living with HIV. They don't even know they have it because they're afraid to get tested, which is unfortunate because then they can transmit that to other people when they could be getting antiretroviral therapy and put their viral load so low that it's no longer detectable and not transmittable. So sexually transmitted diseases. These are important in our community because they're also on the rise in certain populations. It's important to assess the onset of sexual activity because the younger people are that they start having sexual activity, the less likely they are to protect themselves from sexually transmitted diseases, to understand sexually transmitted diseases, and seek treatment if they are having symptoms. So Georgia used to rank #1, yay, for primary syphilis and secondary syphilis, not really the kind of thing you want to be #1 at, right? So that was in 2013, and we have dropped down to 4th in the state. So it's we're doing better, but we could be still making more improvements to STD prevention and knowledge for our populations. HPV is the only STD that has a vaccine, as Gardasil. It's the only vaccine preventable STD. It's also known as genital warts. And the problem with this is that certain strains, there are over 40 different strains of HPV, but certain strains are known to cause cervical cancer in women. The other thing that's an issue with these types of STDs is they frequently have no signs or symptoms. So a lot of times people don't even know that they have them, but they, especially for women, can lead to pelvic inflammatory disease, which can later lead to reproductive issues later in life. Hepatitis is also a bloodborne pathogen that is of significance because it's hepatitis A, you can get a vaccine for. You usually get that through contaminated food or water. Hepatitis B and C are bloodborne or sexually transmitted, and they can cause significant health deterioration for patients and can have long-term lasting effects on life and mortality or morbidity for these patients. I didn't pull this picture, the woman in the lower left-hand corner over there, but it says this is what you get for using dirty needles. Yeah. So, and hepatitis is actually more common than HIV. I didn't have this. I don't have the stats for this, but hepatitis, especially hepatitis B and C, they can live on surfaces for longer periods of time. HIV is very unstable outside of the body. Public health surveillance. A couple of quick objectives. Why is this so important for us? Why is this important as nurses to understand public health surveillance and the role of the public health nurse in surveillance? So infectious disease outbreaks have been occurring throughout time, and public health nurses have often been on the forefront of identifying these pandemics. This particular pandemic that's shown here was Spanish flu that killed about a third of the world's population, had a very high mortality rate. If you want to have some fun and look at some CDC outbreaks, there's a link there for some outbreaks. So public health surveillance is the ongoing systematic collection, analysis, and interpretation and dissemination of data regarding health-related events for use of public health to help reduce morbidity and mortality to improve public health. So this is just a way of collecting data, analyzing the data, and sharing the information back to keep our populations healthy. We'll skip that. So the goal of surveillance is to provide information that can be used for health action by public health personnel. So looking at populations and taking that data that's gathered and figuring out strategies to improve health for our populations, and then turning that into public health policy and economic policy that can help drive better outcomes and better resources for our populations. The sources of data come from all over, and notifiable diseases and conditions that must be reported to public health authorities. That data is always tracked so that we can keep on top of diseases that are prevalent in our populations and make sure that we have the right needs for our population to improve their outcomes and prevent these diseases from occurring. Notifiable disease reporting in Georgia, there's a phone number, and there's also SENS, which is the State Electronic Notifiable Disease Surveillance System. Again, diseases that are mandated, there's supposed to be a picture up there. Diseases that are mandated for reporting have to be reported either through calling the state of Georgia or reporting through the SENS system. Oh, there it is. And this is available online, but most of it are things that people are familiar with or expect to be reportable, such as pertussis, measles. So the surveillance data is used to help identify patients and contact them for treatment and intervention. It detects and controls epidemics and health problems and helps identify problems with behavior that can be changed. Looks at the source of the illness and environmental and occupational exposures. It looks at disease trends. And it helps us to develop hypotheses and stimulate research so that we can help put some of these diseases under tighter control. The process is pretty straightforward: identifying the problem, collecting the data, analyzing the data, disseminating the information, and monitoring and evaluating the usefulness of the surveillance. Is it working? Is our process working? As you can see, there's lots of case reporting and notification that goes through public health and onto CDC, who then develops programs and protocols and policies to help protect our populations. We can skip that one. So the role of a nurse in these situations is a key role in recognizing and addressing these incidents and preventing and treating infectious diseases. You have to know what you're looking for. You have to know what illnesses are in your population. Clinical practice with a population health focus. So again, you might be in a clinic and these are your people, but your people live in the population of the community that you are working in. Building partnerships with other health departments and policymakers. Promoting health, education, and prevention of infectious diseases for individuals, families, and communities. advocating for immunizations or improved environmental conditions in your community, program planning, implementing to reduce incidents, such as community support and health services, doing surveillance, which again might just be, why do I have so many people coming in with this type of skin cancer or this type of illness, and then research, finding out what's available for prevention. And that's it. I'm sorry I ran over, y'all.